Hey, everyone, this is Neil Horn and Lauren Rabinovitz from the TA Network, and we have 2:30 East Coast here. I don't really like to do math in public, Richard, so I don't know if that's like 5:30 your time, 1:30, it's something like that. There's a difference, I know. So we're going to get started here in a minute or so. I see some folks still joining as we sort of hit our hour. I'm going to be quiet for most of the call, but I'll start us off. This is our community practice, and it's open to anyone. So folks, Richard on the phone, maybe from some of the currently funded System of Care expansion grantee sites that are focused on young children and their families. They may not. They may just be interested. We invited folks from our graduated communities, so some of them may be on as well. For those of you who are on, we're super excited to have you as well as our guest Richard. And Lauren and I really see this community of practice as your community of practice. So if there are questions that you have, feel free to sort of type them in the chat box there. We invited Richard Cohen from Los Angeles on this month, and I feel really lucky that he's able to make some time. LA has had 2 System of Care grants and now an expansion grant, and focus on early childhood. And if you can imagine what it's like to try and do systems work in a place as gargantuan as Los Angeles County, Richard and his colleagues there have done some amazing things sort of across the board: social marketing, workforce development, the service array, training. And it's just been really impressive to watch. They're so good that they never want TA, and they rarely, I was surprised Richard was even willing to talk to me and agree to do this. But Richard and I have worked together for quite some time. We had asked him to talk a bit about the workforce development efforts there, and hoping that folks on the call sort of are prepared with some of the issues that have come up for you. But we're going to have Richard start out with a bit of a presentation, but I think, Richard, you'll take questions along the way, correct?
Absolutely.
Thanks. So with that, I'm going to turn it over to Richard.
Good. Thank you. So let's see. I'm going to move us forward a little bit. I am Richard Cohen, and I was the project director for Project ABC, the number 2, and I'll talk a little more about that. I wanted to give you a little bit of context on Los Angeles, which, as Neil mentioned, is a pretty big place. I was just looking at square miles. We are about the size of Connecticut, which has 3.5 million in population, and we have 10 million in population. And I don't say that to say, well, we're big. It's just that it's really complicated. We are divided into 8 service planning areas. And the first Project ABC was in the very densely populated kind of downtown Koreatown area, if you know Los Angeles, which is called SPA 4. The second one, which I directed, was in the physically much, much larger but less populated SPA 8. And they presented different problems and different opportunities, which I'll talk about in a second. But what I wanted to say was, let me go back a second to the title page. From our perspective of all of the work, wonderful as Neil claims it is, which we are very proud of, one of the main keys to sustainability and to spreading the word is workforce development, because whatever happens after the project ends, whatever you've been able to accomplish or whatever things you haven't been able to accomplish in workforce development, the training stays with people. And those people, especially the new ones, if they stay in the field, they become supervisors. And you've had a spread effect that is really difficult to capture, but where you've really transformed people's capacity to work effectively with young children and their families. And so we spent a lot of our, workforce development was one of our 2 or 3 major foci for all 3 of our projects. We're now, as Neil mentioned, just starting a sustainability and expansion grant, and I'm sitting, and it's in what's called SPA 6. I'm sitting talking to you from Compton. So it's the South LA area, which presents its own opportunities. I see that it's a relatively small group, and I'm hopeful that what that means is that we can really have some conversation, either literal or virtual, that you'll ask questions that will, I don't see any reason to hold the questions to the end. If you have a question now, we should deal with it now. So that's my approach to doing this work. I already know this stuff, or I know what I'm going to say, or I wouldn't be saying it. And if I'm saying something that stimulates something for you, not just a question, but a comment, something that your project is doing or thinking about doing, we should share that as a community of learners, and just use me as a kicking off point for a larger conversation about workforce development and training. So with that, we'll go forward. So I don't want to belabor this because I assume that most of you have some background in early childhood mental health, but if you've been in the field for a while, you can recognize just the tremendous and exciting expansion of knowledge and approaches in the last 15 years, and even the recognition of early childhood mental health as kind of its own field. Our knowledge of infant neurobiology, of attachment, the significance of those early attachment relationships and what they mean for social, emotional, cognitive development. Seeing the result of the ACEs studies has really gotten people's attention in a way that we would never have anticipated before, which is a good word for the use of data and how important it is. And all of that, along with the growth of the availability of evidence-based interventions in early childhood mental health, has really changed the field and allowed us to carve out early childhood mental health as early childhood as a special population in the world of mental health that we deal with in a different way from the way we deal with other kinds of therapy, psychotherapy. You can actually put a child in a car seat and then put the car seat on the couch and ask an infant how his week was since the last time we met, but it's not a really effective way to improve their social emotional outcomes. And so in early childhood, as you know, early childhood mental health is always dyadic. And the other piece that's really significant and important is this shift from the traditional medical model of diagnosis and prescription to a more strength-based approach and a more parent-engaged approach. And those things just are not taught yet in most graduate schools. And most of the people who are already out and working don't have that background and need it. And even the people who are coming out right now are mostly not getting that as part of their work, unless they have an early childhood mental health placement. I spoke to a class at USC 2 weeks ago on the early childhood mental health in the early childhood context. USC Graduate School of Social Work has 2,800 students. The early childhood class is an elective, and they had 13 people in it. So, and the class is only given once a year. So, maybe 26 people will take that class by the time they graduate, and that's a very small percentage of the 2,800 who are going to come out with some kind of clinical experience. And unless a few of them have placements, they're just not going to be ready to do this. And then, of course, the whole issue, which we can get into more about, what it means if the entire mental health system is still based on a medical model, and you're encouraging people to use a different model, and even a different diagnostic and statistical manual with some kind of crosswalk. How you manage the billing, how you manage getting your notes in a way that's acceptable. These are all very, very complicated issues, and part of what our training is about. So the first Project ABC started in 2006 when this was all even newer. And Dr. Karen Finello, whom some of you may know, was the project director. And she was very adamant that that the approach for the System of Care grant needed to focus almost exclusively on the development of therapists, that it was unethical to create a system of care to refer children to people who were not trained to work with the population. And so the major focus in Project ABC-1 was developing those therapists and their supervisors who got it and who were ready to take on the task of effectively serving young children and their families. Excuse me. Sorry, if I disappear for a second, I'm coming off of a cold, and I don't really want to cough into the phone. I don't think you'll get infected, but it could affect your hearing. And so the focus was particularly on evidence-based interventions, including, you probably know most of them, child-parent psychotherapy, parent-child interaction therapy, and then in California, we have as local options both reflective parenting and mindful parenting from the Center for Reflective Communities, which are more attachment and based approaches to group-based, attachment-based approaches to working with families, and then the Incredible Years, both the ones for infants and the ones for older children. So that was the body of evidence-based interventions that we were working on developing. And but the other thing that we were concerned about was that while you can be certified in these evidence-based interventions, that there's more to doing this work than certification, that you need to know something, a lot actually, about development, about the lives of children and families, and that whatever you do in a treatment is not just manualized therapy, but really is grounded in your knowledge and your supervisor's knowledge and wisdom in these approaches and in development in a more general way, and in what it means to be off track in development, to be seriously emotionally disturbed. And so we did a lot of work in those areas. And Karen was very involved, as was I actually, in the iCare steering committee. So which was, iCare stands for, right now, its meaning has shifted a few times. We just like the iCare. Infancy, Childhood, and Relationship Enrichment Initial Assessments. And we put together this group. I was a small part of it, that developed both this 13-page initial assessment and a rollout plan for the county that everyone ultimately would be using who was contracted with the Department of Mental Health, that that would be the assessment process for developing a treatment plan for working with children 0 to 5. And what's beautiful about it is that it walks you through all of the major pieces that we want to be sure you're thinking about the child's trauma history, about the child's developmental levels, about the other kinds of communication problems. You guys probably know that we wind up seeing a lot of 2-year-olds with really aggressive behavior. And when we do a developmental screen like the Ages and Stages questionnaire, we find out that the child actually has a language problem and a communication issue. And we would, label this child as overly aggressive and start treatment on the aggression, when what we really need in this case is for somebody to help them with their speech. And it's one of those things that you need to know as a therapist of very young children. Excuse me. If you're going to match the intervention plan with what the children and families' needs are. And so the iCare assessment was unfolded along with the first Project ABC as a way of trying to get that grounded look at the whole child and what are all of the issues that are affecting whatever social and emotional issues are presenting that caused them to arrive to you in your office or that sent you to their house. So that was the core of this, and I think one of the patterns that's important to note as we're walking through this is that, none of your grants is going to be big enough to do all of the training that you want to do all of the things that you want to do. And so from the very beginning, Project ABC was looking for partners, looking for initiatives that were also happening and there are a lot of initiatives going on in a big county like LA. But a lot of them are pretty siloed. And so we were able to pair with this part of the Department of Mental Health that was trying to help the expansion of an early childhood mental health philosophy and practice through the county. And so there's almost nothing that we've done in Project ABC that is just about us or that we can just take credit for. And I think that that's a really important aspect, not just of training, but of having a successful project. $9 million or $4 million if you're an expansion grant sounds like a lot of money, but you go through it pretty quickly. And it's never enough to do all of the things that you want. And you're going away, so you want to be connected to systems that are in place that are likely to continue. But that was the focus, the major push, again, on TABC 1. Not that we didn't care about systems, not that Karen was disinterested in other aspects, but again, that baseline ethical approach which says we're not going to refer people to therapists who are not competent in working with your children. I'll stop there and see if there are any comments for a second and see if there are any comments or questions or ideas. And also to cough, excuse me. Okay. When we moved to Project ABC 2, we had a 1-year overlap with Project ABC 1. And our goal was really to build on what Karen and Project ABC1 had done, but then also to start thinking more about this, about systems. And the key for us in thinking about systems, well, one of the keys anyway, was to build a shared language and a shared approach. For example, 70% of the kids that we work with have child welfare involvement, Department of Children and Family Services. And just getting a glossary together of our different acronyms, and then the multiple meanings of something like primary care provider, which means one thing in early childhood and another thing in child welfare and a third thing in mental health and health. You know, that takes a lot of focus and a lot of time. And, you know, we spent a lot of time trying to find ways to get people in the same room at the same time, hearing the same things. And we felt that was a real key. Actually, forgive me, I'm going to go back for 1 second, because I want to add one other thing that the Department of Mental Health and Karen and the Eye Care Steering Committee put together that was really, really important, because the training money that the first Project ABC had, as I mentioned, would allow for the training of many of the therapists in that particular service planning area. But the other thing that the Eye Care Steering Committee did was to put together a set of trainings that the county offered itself first and now is contracted out. And there was huge demand for these. And they're a set of the trainings on what we think are the minimum requirements for people in order to complete the eye care assessment properly and in order to understand the core issues for any child and parent who are in therapy. And I want to read them off just so you have an idea about them. You guys may have different thoughts about that. So ideally, we've not been able to mandate that no one can work with a child 0 to 5 until they've completed all these courses. We haven't been able to mandate that yet, but we're trying to move in that direction. And we're also trying to integrate this with the endorsement process, which we can talk about a little bit, which California has adopted, but also not mandated. Anyway, here are the courses. Typical and atypical development in children aged birth through 5, brain development and implications for attachment and treatment in young children, best practices in infant mental health intervention, mental health diagnosis of infants and toddlers, using the DC 0 to 3, which as many of you know is now being supplanted by the new DC 0 to 5, a very exciting move from 0 to 3. The next one is sensory integration in children aged birth to 5, trauma response in infants, and then a training in using the eye care assessment. And to me, one of the keys in this is the sensory integration, because it has always seemed weird to me that we spend all of this time talking about the neurobiology of things, and you know how, if you've heard Bruce Perry talk about trauma in children before they have language, and talking about the whole body remembers and cortisol and reactivity and all of those things, and then most of the therapy that we provide is really about you know, the prefrontal cortex and talking to the parent and talking to the child, and not about the kind of sensory aspect that are really critical. So that's one of the things that we were sure to include in the training. And, you know, I may get to this a little bit later, but I'll just drop in here that one of the things that we have consistently provided is training in infant massage. For those of you who don't know it, this is not where the therapist does the massage, but where the therapist, or it can be a care coordinator, it doesn't have to be a therapist, actually teaches the parent to provide infant massage. And we've had some absolutely amazing experiences with that, and integrating that into the evidence-based approaches, partly because under Project ABC, under the system of care approach, you have an integrated kind of approach and a team approach, which includes a care coordinator and a parent partner, because you have to be really careful about how you bill for these things and what you call it. But we have had really good success and some amazing anecdotes from people, particularly family, kin caregivers in child welfare systems, about the connection that's built using infant massage as an intervention. So forgive me for going backwards for a second. So in Project ABC 2, again, just getting myself back on track, the key was to building a system is to create systems that enable and encourage the connections of the individuals across the silos, across disciplines, across funding streams, who are working with the same families. And one of the ways to do that is to be sure that you're getting people in the same room who are hearing the same information, and that while they're there, you're helping to build those personal relationships. I don't mean to imply that systems are personal relationships, simply that the function of systems is to create a sustainable structure within which people can work really comfortably and are more likely to collaborate. Because it's not just a 35,000-foot approach. And so along with continuing our focus, along with continuing our focus on certifying people in evidence-based treatments, we have also really begun to focus on these interdisciplinary approaches. The one thing that we really wanted to do, and I would encourage you to think about that we didn't get around to doing, is to use a touch points training, although some of the agencies, including Children's Institute, where I am, instituted touch points training. But in my opinion, it's the most powerful shared language and shared approach, and the most comprehensible for people of very, very different backgrounds and trainings of all of the approaches that we looked at. But we did some interesting things to encourage people to show up at places, or for us to show up at people's places. Excuse me again, one second. And again, as with Dr. Finello, we were very fortunate to have as our lead in the training for our system of care, Dr. Lisa Alton from the Department of Mental Health, who worked at one of their directly operated clinics, was also the coordinator of the 0 to 5. Each service planning area has a 0 to 5 collaborative, and who also, as I said, was our training coordinator. And so again, we were able to draw on some systems that were already in existence and were likely to be maintained after the project ended, because for those of you who are early in the project, the 6 years are over really quickly. And you'll have your final closing meeting and party and wonder how that happened. So one of our goals was to get this interdisciplinary approach, which we tried hard to include early childhood, the Part C providers, which in Los Angeles, in California, are called the regional centers, health, mental health, obviously, and the child welfare community. And finding times when everybody could be in the same place at the same time was very difficult. And we often had a small fee. We tried to keep our fee as low as possible just to cover our expenses when we would have an expensive speaker. But we did have to charge something. And so finding ways to make this happen was complicated. And one of the first things that we learned was, and this is the beginning of our entrepreneurial approach to this kind of work, one of the first things we learned was we can trade slots in the training for venues, and that takes the training out to the people whom you're particularly targeting. You have to be clear about whom you're targeting. So, for example, over a 3-month period, we had a series of trainings which we held at the regional centers, at our Part C provider in our area, who had a great training room. And the trainings were on Connie Lillis's neurorelational model, which is a really powerful approach to understanding children's and parents' self-regulatory capacities and tying your intervention to improving and supporting those capacities. I don't know how well known she is nationally, but in the state of California, she has one of the key models that we use here. And we had her come to the regional center, and we'd had a terrible time getting the regional center people to participate, finding things that would be valuable to them, and then finding ways, especially as we were going through the economic downturn in 2010-11. It took California a while to come out of it. And they didn't have a lot of money to spend on training. But as I mentioned, they had a great training site. So we took the training to them. We did similar things with the child welfare department, where we really wanted them to be involved in the training and to get the children's social workers and the supervisors of children's social workers to start thinking about the 0 to 5 population as a separate population that needed separate handling. And we had 2 offices in the part of the county that the Project ABC worked with. And what we did was take the trainings to their training rooms. Now, we invited other people, and a lot of the people who came to those trainings who were not DCFS staff had never been to the child welfare office before and hadn't met any of those people because they're under really tight time frames and productivity demands and don't get out to a lot of training that isn't provided right in their site. We worked with the regional administrators and assistant regional administrators at the offices to pick the best times possible to get their staff there, and then invited other people. We also negotiated, and they're really tough negotiators, how many slots we would give them for free in exchange for being able to use their offices, their training rooms. We did a similar kind of thing. Excuse me. We did a similar kind of thing with our training on trauma, where we combined, Children's Institute was at the time part of the National Child Traumatic Stress Network and had an annual conference, which was relatively expensive, but by providing some free workshops as part of that conference, we were able to exchange some reduced rates for DCFS staff, for funded, contracted Department of Mental Health staff, and some other targeted people that we really wanted to have attend. And then one of our other major foci, because as you guys know, this is stressful work, was to deal with issues around secondary trauma, compassion fatigue, and self-care. And what we did was tie our training to the National Child Traumatic Stress Network conference and have one of the people who came out from Canada do a separate training as long as NCTSM had already paid for her airfare, and we had her. And again, we held the self-care. We did this 2 years. We held it at different offices of partners that we were particularly trying to target. As you can imagine, we're particularly concerned about self-care for the children's social workers in the child welfare system. I think about their emergency response workers who, go out when something bad has happened, along with the police and the public health nurse when there's a child 0 to 3. And that's really tough work, and we want them to stay in it. So those are examples of ways that we were able to target specific populations, which allowed us to get the right people in the room that we wanted to hear, but also then invite other people who would be there with them and develop relationships. Excuse me. One of the other things that we were most proud of was in the project was our commitment to the parent voice and the role that the parent partners played, going well beyond what we had ever planned. They just took the ball and ran. And so we were able to have a special focus on the ways that we integrated the parent voice into all of our trainings. So firstly, they were invited and we paid for them to attend any of the trainings. And we had, in Project ABC2, we had 4 funded partners. So we had 4 parent partners and a key family contact who, as I started to mention, became a powerful unit in and of themselves. And I should point out that both the key family contact and a minimum of one of the parent partners attended every one of the training meetings that we held. So it wasn't just that the parent voice was in the training, but the parent voice was in the planning of the training as well. And they became partners with us in all of those things. I'm just really pleased with the way that that we were able to support them, and I'll talk a little more about it. So the first thing is that they got to go to all of the trainings, and they were also participants or trainers with us in a number of our trainings, which was very pleasing when we were able to get that, not just that parent voice, because they weren't just representing themselves, but they're working with all of the families that we're serving and have, as you may already have experienced, a different relationship with the parents than the therapists or the care coordinators, a more intimate relationship that we really want to learn from and draw on. And so we did a number of different trainings in which they participated. And we also developed a special track. We provided them with some special training. That 2 examples are, there's a wonderful national program that Sandra Gutierrez has put together called Abriendo Puertas, which is available in both English and Spanish, opening doors, which is a parent-focused approach to families, to working with families. And all of our parent partners and the key family contacts completed that training and then became presenters. We also did, in Northern California, there's a wonderful kind of relationship-based paraprofessional program called Hand in Hand, which we liked very much. And we had all of the parent partners and the key family contacts become facilitators and trainers in Hand. They went through the training and then they did that. They became trainers. One of the things that the training did was to really transform their work with the parents and help them develop that kind of paraprofessional approach where the lines between a paraprofessional, someone with lived experience, and the parents are osmotic but clear, if that makes sense. It's often an issue working with parents who are what we call natural helpers. But the parent partners became, they met separately and became a group, and they began doing trainings, for example, in preschools. They did parent evenings. We worked closely with both the Long Beach Unified Head Start program, which is a pretty large program, Head Start grantee in the south part of the county, and also, excuse me, Long Beach itself has a city-funded early childhood education committee, which has been very active for about 40 years. And through that, the parent partners got connected with individual early childhood sites where they worked with teachers. They did parent evenings. It was really very, very exciting. So they had a voice in a way that we had not anticipated. All of this, none of this was in our the plan that we submitted to SAMHSA. It emerged because the opportunities were there and because this group bonded in such a powerful way, and we kind of went with it. An example, getting to how the ways that they worked as presenters. One of the things that we did, because we really appreciate the fact that more than other systems of care grants, the early childhood mental health system of care grants are focused on prevention, have an added focus on prevention and promotion of social emotional well-being. We were able to get connected with a movement in LA County to dramatically increase the home visiting home visiting system that's developing rapidly. And there are a number of different funders of home visiting in LA, including McVie, which is a federal program. But we have some state programs and some county-funded programs. And so we have had the opportunity to work with over 800 home visitors, 799 of whom were women, to provide training in the ages and stages questionnaire, in the in developmental milestones, and importantly, I think, in integrating the screening process into developing your relationship with the family, so that it's not an isolated check-off-the-box kind of thing, but it's part of, and this is a kind of touch points approach, first, supporting your relationship with the parent, and secondly, and more importantly, supporting the relationship between the child and the parent. And so one of our amazing parent partners, Consuelo Iglesias, and I do these trainings together, and I have all the theory, and she's done hundreds and hundreds of ASQs in the last 12 years or so that she's been working as a parent partner. she started before we were fortunate to grab her out of another program. So that's been a huge value to the prevention aspect of the system of care. And it's also enabled us, our connection through that training has enabled us to develop relationships with all of the individual agencies that are working on prevention, and will be referring some of the families that they have concerns about, some of the higher risk families, for early childhood mental health therapy, assessment and therapy. So that was very valuable, and again, unexpected kind of approach. And for those of you who have federal matches to meet, we were able to count the money that was not federal as as part of our non-federal match, because it was new and not already scooped up by someone else's match. I'm looking to see, let's see, there's a question here. We're building a referral system. When I hear you say it's unethical to refer to those unqualified, what benchmark should we set as a standard for qualification? What a really great question. Let me just say that the standard is raised over time, right? And we've been fortunate that we've been able to raise the standard. And there, we had a huge amount of conversation before we actually decided this, and you know, it was a moving target. So I'm good at giving examples and giving you things to think about, and since I don't know your community, I want to be more careful about making declarations. So I do think that you should be thinking about what's ethical, and, you know, is it better for someone to have treatment for someone who's not sure what she's doing than no treatment, or, you know, at first do no harm, right? So let me see if I can say something useful about that, because it's really an important question. The first thing I'll say was that it was a negotiated standard. And we had some wiggle room in LA County because we have two major funding streams for early childhood mental health. We're using EPSDT, early periodic screening, diagnosis and treatment, for one of our major funding streams. And right now, they're not, that's Med-Cal dollars, and they are not requiring evidence-based approaches. On the other hand, we have our other major funding stream, which is specific to LA California. We have a special tax on people earning over $1 million a year that pays for the Mental Health Services Act, and there is something called and a big chunk of that goes through prevention and early intervention. And one of the requirements for prevention and early intervention is that one uses an evidence-based approach, something that's been approved by the California Institute of Mental Health as evidence-based. And so the goal, though, is to maximize the use of those dollars and to shift as many people as we can into that funding stream and leave the looser, the easier to meet requirements of EPSDT. That's terrible syntax, but I think you get what I'm talking about. So here's what I would say. If you have a therapist who is not yet qualified in an evidence-based approach to early childhood, now I'm speaking just as me now, but also trying to voice the conversations that we've had over the years. The first thing that I would say is her supervisor better know something about this. And that supervision is really key. And the supervisor can bring people along if she knows how to ask the right questions, and particularly if she has training in reflective supervision, which has now become one of the core EMH courses for supervisors in early childhood mental health. I would also say that my first priority would be that they get some experience, some knowledge of child development and the tools for assessing it. Because if the supervisor is knowledgeable in early childhood mental health, then she can use the assessment that the therapist brings to her as a way of developing a treatment plan to work with the parents. But it depends entirely on the therapist being able to see what's actually there, and to understand something about reactivity, about states of regulation, transition from different states, all of those kinds of things, developmental levels and screening through the ASQ. Are there delays? I personally would put the focus there first, providing you have a therapist, a supervisor who has the background. So I don't know if that's a helpful response. Okay, any other type of questions? The negotiations going on here, since there are only 13 of you, and give us about opening this up in a second more broadly. So I'll let you know, they'll let you know when it happens. So another one of the things that we did that the training committee did under the guidance of Lisa Alton was to develop guidelines that we gave to everybody that we brought in as trainers, from Connie Lillis to whoever else it was, including some of you may know George Downing and video intervention therapy. He was in the country, and we were able to bring him to Los Angeles to present his really amazing approach. But we wanted to make sure that anyone who was making a presentation understood the system of care approach, not just the early childhood mental health approach, but the system of care approach, and that they were thinking about big C culture and small C culture, that they had an idea about how diverse linguistic, how many different language communities we have in LA. You may not know that we have the largest Cambodian population outside of Cambodia in Los Angeles County, and just south of us in Orange County, the largest flowing into LA County, the largest Vietnamese population outside of Vietnam, and that's just a couple. We have the largest population of American Indians in the country, but not in individual tribes. So the diversity here is immense, and people have to be able to think about how to address that when they do training. It's not enough to just take it off the shelf. And this is particularly an issue with evidence-based treatment, because as most of you know, in order to become evidence-based, you have to narrow your population enough, the population that you're testing on, so that you can, tell that it's actually the treatment that's working. You don't want dual diagnoses. You don't want you want to limit the variability as much as possible so you're clearer in developing these evidence-based treatments, that it is actually the thing that you're testing that's making the difference. And what that means is that it presents a real challenge to use those evidence-based treatments with communities that may not meet the standards that they're normed on. So we want people to be thinking about that when they come in. And we also want them to be thinking about addressing interdisciplinary audiences and to be thinking about ensuring that there's a parent voice, either by including one of our parent partners, which was an option which actually no outside speaker took the opportunity to avail themselves of, or that they were at least thinking of this from the perspective of a strength-based, parent-driven approach. Because what we didn't want to have happen, excuse me, what we didn't want to have happen was to not take advantage of have the trainer come in, do some kind of canned training, no matter how wonderful, walk away, and then leaving us trying to figure out, okay, now what do we do with this? But we wanted that whoever came in, whatever his or her expertise was, to help us think about how to adapt this to the families that we're working with, and ideally to draw on their experience making those adaptations themselves to see what that could mean for us. And rather than, point fingers at them, or, we use this presenter guideline as a way of opening a conversation. And it was what came to them while we were working on developing the contract for their services. So very early on, we wanted them to be thinking about what they were going to present. We wanted them to be adapting both to the system of care and to the context of LA County, and particularly South County in LA, and to make it a dialogue. So we found these presenter guidelines to be very valuable. Excuse me one more time. Or maybe not one more time, maybe more than that, but we'll see. It's very quiet out there. I'm wondering if you have any more questions about that. Okay. One of the things that I also wanted to talk about, I'm going the wrong way. There it is. And I've already started to mention it, was keeping sustainability in mind from the very beginning. I know that we all have to put it in our, in our twice annual reports. I can't remember right now if that's semi-annual or biannual, forgive me. But we got to write these reports twice a year. And you have to say something in your very first report about sustainability, and think, oh my God, we haven't even started yet. How can I think about it? It's not too early to start thinking about it. And the key, as I've tried to mention, the key for us anyway, was to begin thinking about the people, the institutions, the initiatives that are going on in your area that are either already there or emerging and that are likely to continue. So how do you find partners for your trainings? How do you find people who are already doing things that are similar to yours, that you can build relationships with, and that will continue and be the sort of nexus of training when your 6 years are up? The other thing that we were able to do was to use what the airlines are using now, which I know drives you crazy. It drives us all crazy. But to use variable pricing. So we were able, in trading venues for slots, we were able to give away some slots. And then we were able to charge low prices to our partners or targeted groups. And then we had higher prices, the kind of charge that you would have for a full day or a 2-day program in any other training to people who were outside of the circle that was the immediate responsibility of our system of care grant. And by doing that, we were actually able to build up enough of a resource to be able to fund some rather expensive trainings. Connie Lillis's 3 neurorelational model trainings were more expensive than money we could earn by offering the 3 of them. George Downing was another example of someone who was quite expensive. Excuse me. But whom we paid for by surplus from some of the other trainings that we provided. We did a lot of training slots, as I said, for venues, partnering with people, and being entrepreneurial wherever we could. The one thing I want to say to those of you who are new to this, and we're not that many of us who come from the program side are not highly trained in budgeting and federal accounting, especially if this is your first grant. One thing that I want to make sure that you know is that you need then to set up a separate training account where revenue goes, even if you're paying for part of the training out of your SAMHSA budget. Revenue needs to stay in a separate account. You don't want to mix the federal dollars with any kind of income that you get. It's not that it's illegal, it's not that there's any problem with it, but for accounting purposes, the federal dollars want to stay your auditors, and should you be audited by the federal government, you want to see that they are braided and not blended. And that was something that I had known because I was a Head Start director before this, but which a lot of people don't have much experience with, and you can get into some kind of very messy technical things, which your finance department should be able to save you from, but if this is the first time you've had a federal grant, they may or may not be able to do that. That's the core of what I wanted to present. There's so many details that I could talk about, but much of it depends on whatever is interesting or at least not boring to those of you who are also on the call. So I'd be happy to turn it over to Neil and Lauren to see where we go from here.
Hi, it's Lauren. Richard, thank you so much. This has been extremely useful. I think I can tell we're getting more questions and participation than I think we ever have before. So this is excellent. I highly encourage everyone who's on the line to take advantage of having this amazing resource in this time right now. So I believe that Gary is going to be opening up the line. So if anyone has a question, so phone lines are now unmuted. So please feel free to ask away and take advantage.
Oh, I'm seeing Annie Mac's question about Kansas. Ann Mac has a question.
Go for it.
We have rural. Can you hear me?
Yep, go ahead.
Good. We have her question. Can everybody see the questions, or is it just me? I'm not sure.
Yep, everyone should be able to see them.
Okay, so Ann's question about telemedicine or some other virtual medium. Wow. Actually, I know Kansas a little. My sister lives in Topeka, which is not rural, but you get out of there pretty quickly, out of urban pretty quickly. The only early childhood approach, the early childhood mental health approach that I'm aware of that you can even begin to think about through virtual delivery would be, I mentioned George Downing's video integration therapy. And that is not an evidence-based treatment, at least not in the United States. He is in Switzerland and Germany and France. I think he's based in France, but teaches and provides supervision all around there. And you might look into that because it's evidence-based. But not, I mean, except parent-child interaction therapy we provide in clinics. But almost all of our other work, particularly child-parent psychotherapy, we go out to the home. And this is, it's a really interesting and important question. But the intimacy of the kind of work that happens in what Ed Tronick would call the dyadic expansion of consciousness really requires, at least initially, the development of that kind of intimate triadic relationship with the therapist, the child, and the parent. And I can sort of imagine a way to do that virtually after that relationship is established, but somebody's got to be out there. I mean, one of our major costs in the project is mileage, because we get the therapists out to the homes. So that's not a very useful answer, but I recognize that there are many places in California as well that are really far from anything. The next one, were you successful in receiving Medicaid reimbursement for any of the services provided? Yes. Yes, we were. The trick, actually, for child-parent psychotherapy, for parent-child interaction therapy, for reflective parenting, for Incredible Years, and those last two are groups. Not yet for mindful parenting, which is a group that has the babies with them. We were. It really is you really have to be careful how you write the notes, because this is not lying. This call is being recorded, right? So I want to be really careful. But you have to become an expert in framing the notes around the child, because unfortunately, even though in early childhood mental health, and those of you who are Alicia Lieberman fanatics the way I am, Alicia always says the dyad is the patient, right? And yet, from the DMH's standpoint, from the Medi-Cal standpoint, from Medicaid standpoint, which is called Medi-Cal in California, sorry. From Medicaid standpoint, the child is the client. So it's really about learning to write your notes in ways that focus on the child, even though the way to help the child is improving that parent-child relationship. One of the major issues is meeting medical necessity, and that is often a problem. So here's an advocacy issue for you, right? There are states, I think it's New Jersey is one of them. I heard Neil, you may remember this because you were at the presentation at one of the national conferences, where a child with a substantiated case of abuse or neglect is considered ipso facto to have met medical necessity, and it is a state barrier that is not the case. If that is not the case in your state, that's not a federal issue. That's a state issue. We have thus far been unsuccessful in having children qualify simply because they have an open case or a substantiated case of abuse or neglect. But there is movement in that direction. And yes, so we were able to access quite a bit of EPSDT funds The other thing that I'll say, and at the national conference we saw a bunch of these, but we also have them within California, is that what's really very useful in terms of meeting medical necessity is the crosswalk that your state will accept between DC 0 to 3R and DSM 4 or now 5. And we're in this strange period of transition, right? And there's ICD-10 in the background of all of that. But basically what you want is not a, if you see this or if the peer gas is 64, then call it this, right, adjustment reaction, but something a crosswalk that's much subtler than that and more nuanced that allows you to do an assessment that is based in early childhood mental health and then figure out what the appropriate diagnosis is for DSM-5. Yeah, I don't know if all states have transitioned to that, so I'll just say DSM. What the appropriate diagnosis in DSM will be that will allow you to demonstrate that you've met medical necessity. So I don't know if that's helpful, but I hope so. Do you use DC 0 to? No. So I sort of just answered that. Unfortunately, in California, DC 0 to 3 is not accepted. And I think it's an ICD-10 issue rather than a DSM issue, but I'm not really a major expert in this. But that's why you need a crosswalk that helps you. We strongly encourage you to use DC 0 to 3 and to get trained in the new and about to emerge DC 0 to 5 in making your diagnoses, because it attunes you to the major issues in early childhood in ways that DSM still doesn't, even DSM-5 still doesn't. It's just not that nuanced about very young children and that dyadic. It's not rooted in the dyadic relationship. It's still rooted in what the hell's going on with the child. So we strongly encourage people to use that DC 0 to 3 or R or the new, and then eventually the DC 0 to 5, and have a crosswalk that takes you to a DSM diagnosis.
All right, looks like that question was just answered. Other questions for Richard?
Belabored, I would say, on my part. But
very thorough, I would say.
I feel really strongly about that one, and I don't know what happens in other states, but I really worry about using DSM diagnoses, again, because they're not dyadic, and they don't get to the heart of what it is, the way we're trying to treat the dyad.
Yeah, for sure. Other thoughts, questions? If you're not a fan of speaking out, you are welcome to still use the chat function. Okay, well, while everyone is thinking about whether they want to pop up one last question, I do want to let everyone know that next month, in March, we will not be having one of our learning communities, but we will start up again in April. So the next scheduled community is for April 17th from 2:30 to 4 o'clock Eastern Time, as you see on the screen. And as Neil was saying in the beginning, please do let us know if you have thoughts, if you have ideas for future speakers. I think this workforce development it's a big topic, so we probably could even dive deeper next time if there's a certain area that folks are interested in. So please feel free to get in touch with myself or with Neil, and our information was sent out, but feel free to get in touch with the folks at the TA Network if you want to get in touch with us, and we're happy to talk further. I'm just going to ask one more time, are there any other questions before we wrap up? No? Oh, like Anne might have a question. Oh, just saying thank you. Absolutely, yes. Well, I cannot thank everyone enough for joining us, but also big, big thank you to Richard for giving us such an excellent, comprehensive, yet digestible understanding of the great work that has been done in LA. So with that, I think we can wrap up. So we'll give everyone 15 minutes back in their day. So thank you all so much, and hopefully we'll catch you in a couple months.